So I believe the next speaker is from RHC. How does it work with the keynote? There's no questions. Is that correct? There's no questions. Okay. I think the RHC person, you're going to present. Thanks.
Hi, everyone. My name is Sandy Conradi, and I'm presenting or representing RHC this morning. And it's my privilege to introduce Dr. Gillian Saluji. So she is a pediatric physiotherapist with a special interest in working with children and young adults with cerebral palsy and their families living in rural resource-constrained settings, promoting access to quality intervention and excellent services for children and young adults with CP, irrespective of where they live, has been the driving force behind her work. She is the founder and former executive director of Malamalele Onward, at the current chairperson of the Southern African Academy of Childhood Disability, and an honorary senior lecturer in physiotherapy at Fitz Department. And I've had the privilege of working together with Gillian quite closely. Gillian helped us at Madweleni setting up our CP service. It was just such a privilege to work together with her and get her ideas and her input and her team's input into our CB talk. Gillian, thanks.
I feel like Kenya can say for what I say for that thing. But Kenya say for to
Good morning, everyone. Like Warren may have done a lot of talking in the past. That doesn't make you any less nervous of a new audience. I want to say what a delight it is for me to be here today. I want to thank RHC for this honor and for this opportunity to come and talk to you about a field that I'm totally passionate about, people with cerebral palsy. I say that as a warning, because once I get going, it's hard to stop. There's just so much I'd like to share with you. Way back, 1986 and 1987, probably long before you were born, probably long before even your parents were born. I spent 2 years at Elam Hospital in Limpopo. It was the dark, dark days of apartheid. And most of the doctors in Limpopo and the rural hospitals, we didn't really call it rural, it was just out there, were expats from Switzerland and from Holland. And for the first year I was there, I had a physio colleague, Joelle Aselmaiden, and she left at the end of the first year, and I was the sole physiotherapist for 5 hospitals. So every month I would get in my car and do a little round trip around Limpopo and go and visit the hospitals. I was a young therapist. I was clueless. And here I was trying to help other people. It was difficult. It was difficult. Professionally, it was very isolating. I'm so glad that today you've got organizations like RHC, RHC, RENESA, and things like the organizations like the Rural Seeds. I just wish they'd been around when I was there. It was with a great sense of guilt that I left Elam after 2 years. And one of the reasons that I left was that I felt so utterly useless as a therapist, particularly when it came to working with children with CP. Parents would would wait for a long time to be seen by a therapist. And I have very clear memories of, we would do up to 7 clinic visits in a day. So by the time you got to your clinic at 3 or 4 o'clock in the afternoon, someone had been sitting there since this morning, and they got you tired, exhausted at the end of the day. Driving those roads was not a joke. And then here was this stiff child, and they look to you for an answer. And it really was very, very disempowering. So after I left Elam, I went to, but I must say, but also looking back at that experience, I realized how much I took for granted in that the community health doctors that were there area at the time, the likes of Max Price, Nicholas Crisp, Eric Buch, Carl Aselmaiden, really the pioneers of community health and primary health care. And the care groups at Elam Hospital are absolute legends. And I just kind of took it for granted that that's how health services worked, that there was a total flow and a very holistic view of health services. But I left to go and, but it was at Elam Hospital feeling so useless when it came to working with children with CP that I left and went to go and work at a special needs school. And from then on, never looked back. So all I say, I'm a physio. My husband is very upset with me that he doesn't get his nice massages. My friends look at me in horror when I tell them I don't know how to treat a back or neck. But give me anyone with CP and I'm in my element. Cerebral palsy has never enjoyed a high profile in hospital services or in rehab. It's not sexy, it's not glamorous. Children don't get better. Children grow up and the problems actually get bigger as they grow. So it's somewhat ironic that today CP services have become kind of the hot topic. And that's been forced upon hospitals by the onslaught of litigation that have really wiped out hospital budgets. But I see that also as an opportunity as a healthcare professional. I've been a very unwilling participant in the medical legal process. And it's a situation where you have lots and lots of experts giving lots and lots and lots and lots of reports about what a child needs, what the future healthcare needs of their child are, and arguing ad nauseum about whether the child needs a 90,000 rand standing frame and 100,000. The process that the child, him or herself, is really but it's an opportunity where I've been really had to ask the question, what would children with CP look like? And how much is enough? As a therapist, how much is enough? There are no straightforward answers to that. So what I present worked on Word gave me a wonderful opportunity to support and help therapists in many, and children and mothers in many private practice for a while. I have worked at a Centre of Excellence in London. I've worked at a school. So I've been fortunate that I've seen children in different contexts, and from that been able to see what is it that all children have in common. And for me, most importantly, every child they live deserves the very best. And just because a child is in a rural area, just because a child is in a poorly resourced setting does not mean they don't need the very best. And I believe the very best is possible, irrespective of where the child lives. So, and is it possible? So where are we going in this talk? I'm going to give you a very brief introduction to CP as a health condition, just so that we're all on the same page with understanding who are we talking about. I'm then going to share with you something about a short overview of the current status of children with CP in this country, and then ask the question, what is it that we want to achieve through our intervention? What's the purpose? CP is a health condition for which there is no cure. So why are we trying to do anything? We can't make anyone better. So what is it that we're aiming for, and then how to get there? Going the wrong way. So which direction do you point this in? I think I've got that right. Yeah, got it. Thank you. Okay. So firstly, what is CP? So it's primarily a disorder of movement. That's what defines the condition. All children will have difficulty with moving, and because they've got difficulty with moving, they're going to have difficulty with functional activities. What I mean by that, using your hands, eating, drinking, moving around. But in addition to that problem are accompanying impairments: cognition, sensation, perception, behavior, epilepsy, communication, and secondary musculoskeletal problems. And that makes it a very complex condition. It affects multiple systems, and it's not a homogeneous condition. Every single child has their unique set of abilities and unique set of challenges. And that's what makes it really hard to try and find a treatment or an intervention which works. It's not like it's a diabetes and you've got a tablet and you take it so much per day. Every single child is different. So it's the complexity of the condition as well that many people also have problems with vision, hearing. Only children that have CP. Children grow up. CP doesn't leave you when you become a teenager. And all our services are really geared to looking at the child and what happens to the teenagers and what happens to the young adults. So it's a condition that's lifelong and for which there is no cure. If we have a look at how many, that's the first question, how many children are there? So Jackie Cooper is here, and she, years and years ago, when she was working up at Manguzi, she did a community-based study in which she found there was the prevalence rate in that community in South Africa was 10 per 1,000. So this graph tells you Nutu in South Africa, Nutu's in KZN, and I did a community-based study there about 4 or 5 years ago, still in my computer, waiting to be published. But the rate that I found there was about 3.5 per 1,000. And that is for children under from 0 to 14 years. If you compare that elsewhere, Australia is one of the gold standards. The work that they've done in bringing the prevalence rate down is phenomenal. And they're sitting at a rate of about 1.4 per 1,000. Our figure in Nutu, I was out of interest, is similar to the figure in Bangladesh, which is about 3 per 1,000, and similar to Uganda, which is 2.7 per 1,000. So I think if you want to know how many kids there are under the age of 14 in South Africa, it's nearly 60,000. How we understand and how we talk about children with CP, this thing called the GMFCS gives us a common language to describe the population of children. And the GMFCS, if you work with CP, this is kind of 101. Every single healthcare worker who works with children with CP should know and understand the GMFCS. It gives us a common language. Basically what it is, it divides children or it classifies children into 5 groups, depending on how they move. And that makes it very easy to plan services. Instead of saying the child's a spastic quad or DA, and what you call a diaplegic, is that what I call a diaplegic? Is what's the difference between a child who's dystonic and a child who's spastic? Whereas this, have a look at it from a functional point of view. So level number 1 are those children who can walk, run, jump, hop. Okay, so that would be like a very able-bodied hemiplegia. Level number 2, children that can walk on their own, but won't be able to run, jump, or hop. And if they walk up and down stairs or slopes with a lot of people, they'll need to hold on. Level number 3 is children who can walk on their own but need kind of assistive device. Level number 4 are children that can move around on the floor by any means, rolling, pushing themselves on their backs, creeping on their tummies. They can change their position and they can get across a room. With a lot of help, they could walk with 2 people holding them. They had a very fancy gait trainer, they'd be able to walk with that. But their method of mobility is usually some sort of getting around on the floor, crawling. And then level number 5 are those children who are unable to change their positions, unable to turn over. So immediately, if we talk about level 1 to 5, if I'm talking about level 4 and 5, you know that those children have great difficulty in moving and will be quite dependent on caregivers and on assistive devices. Whereas your level 1 children will generally be children that are mobile. So if we then have a look at how do these levels differ across the world, and what's really interesting is how similar the profile in South Africa and Bangladesh is. South Africa is 59% and Bangladesh is 51%. More than half the children are level 4 and 5. Okay. So we have to also unpack and understand the reasons for that. In Australia, most of the children are level 1 and 2. So, and I think those figures are probably similar to what you'd find in high-income countries, where the majority of children are level 1, 2, and 3. And that's also a problem because a lot of the research comes from high-income countries will focus on children in level 1, 2, and 3. And it makes it very difficult to say, well, that's great, but that doesn't work for children in level 4 and 5. So this graph just indicates that the children that we have in this country are more severely disabled and also have more accompanying impairment. So relation of children compared to high-income countries. This was also the data from Nutritional. 71% have a cognitive impairment, half of them had a visual impairment, 40% had epilepsy, and 9% had a hearing problem. Okay. This is a figure from Uganda, and what that basically shows is that for each of those levels, there's a profile that predicts what happens over time. And when they compared the cohort of children in Uganda compared to a cohort of children in Sweden, for the same level, the children in Uganda never reached the same potential. So that means all those little dots there are below the curves. So, and that hasn't been done in South Africa, but I'm pretty sure you'd find something similar. That although the children may be in the same levels, within that level, they never reach their full potential and they drop off that curve more quickly. Also in the Nutritional study, I'm sorry, still sitting in my computer, only half the children are accessing therapy. Almost all children will have access to therapy at some point in their lives, usually in the first 2 to 3 years. So when you ask them, have you ever had contact with a healthcare service, 90% of them will say yes. But if you have a look who's currently attending therapy or has attended at least once in the last 4 months, only 50%. So that's also useful for departments to know that you probably are only seeing less than half of the children who actually need your services. 15% of those that needed devices have been fitted with what they needed, and only 11% were attending school. Access to therapy in the public sector. So these are my own calculations. On average, children get seen once a month. That's usual. That's kind of historic. They may get seen, this is for therapy, they may get seen as an individual session, or they may usually get seen in a group session. But so on average, they're probably getting 45 hours of therapy per year. That's if they attend quite regularly. And there are very few children that actually do attend every month. And then about the age of 7, most children stop attending therapy. Can either be the therapist says, hey, sorry, nothing more I can do for you. You know, the condition hasn't got better. But the therapist say, no, or the mother's given up hope. She doesn't see any change, or she's got other priorities in her life. And the money that she would have spent on transport, other children to look after and to feed. And really, you're going and they're telling you the same thing every month at the clinic. So on average, I think children stop attending at around the age of about 7. So that means that a child in South Africa in the public sector will probably get about 35 hours of therapy over their lifetime. It's no secret that the care for children with CP as a generalization is woefully inadequate. If you look at it from all aspects, the amount of therapy that children get, or the frequency, the dosage, what it is that the children get, how long they wait for equipment, etc. Therapy is often outdated and based on outdated principles, not current. The priorities are younger children, very few services at all, if ever, for children as they get older. The only time you'll see someone, an adult or teenager with CP, if they've come in for an acute health condition. Okay, so away from the doom and gloom, what would an excellent service want to achieve? And I suggest to you that an excellent service is to enable and promote maximal participation and inclusion, and to reduce the secondary problems and the impact thereof. The words participation and inclusion are the key words in CP. That's what we want. How do we make it possible? What do we need to do to make it possible for every child with CP to feel included, to feel part of the family, to be part of their communities, and to have opportunities to participate? And we know that as they grow older, the secondary complications, particularly the musculoskeletal, how can we can't take those away, can't. But how can we reduce and minimize them? So let's dream a little bit. What would an ideal service, what might an ideal service look like? Could we dream of a world where every individual, not every child, every individual, a child, a young adult, a teenager, feels loved and valued, is healthy, feels included, has opportunities to participate, and is pain-free? So, current condition is that children are feeling isolated, excluded, not reaching their functional potential, and there's accelerated musculoskeletal deterioration. What's the target condition? We want children, all children, to feel healthy, included, have opportunities for participation, and be pain-free. How do we fill that gap? 10-point plan. Okay, so I'm going to go through this plan with you, and this is Gillian's plan, which I present to you. Very well open for discussion. Throw it out, add to it, agree, disagree. The principles that underlie this 10-point plan is the principles of universal health coverage, which if you're in rural health, I don't need to tell you about, as well as the framework of the ICF, International Classification of Functioning. So that's what's underlying these ideas. Okay. The first point is that health, social and educational, and I must also tell you where some of these ideas have come from. It's come from a lot of the work that I have been doing, being, as I say, an unwilling participant in medico-legal or negligence matters, and working together with Professor McKerrow in KZN, who's drawn up a brilliant profile for management of children with CP in the province. So health, social and educational services all share focus on integration and inclusion. So that's where our ultimate aim is: integration and inclusion of the child into the home and into family life. So this is all about alignment, and I would suggest to you that the current situation of health, social, education is very much looking like the top drawing, where we're all going in different directions. And wouldn't it be nice if we all shared the same vision? So for that point, I ask you, do you think that's possible? I don't think so. Screening programs for, so that's just being very cynical, or maybe just realistic. Screening programs and early intervention services are available at clinic level. Now, this is an area where there's been enormous strides in information and tools available. So there are very good tools available that you can predict CP very early on. And the two assessments that you can use are the Prechtel's gross motor assessment and the Hammersmith infant neurological exam. So I won't tell you all the details about them, but they are very good in predicting. So if they can use as screening tools for predicting which children are at risk of developing CP. So they are there. And it's from very early on. And the HINE in how the scores at 3, 6, 9, or 12 months, that there's a very high correlation with how the functional outcome of that child. The good thing about these tests is that anyone can do them. Yes, you need to have some training, but they are not terribly, the practical method does require a 3-day training course, which isn't cheap, but the HINE is very easily available. And then, I don't know if you're aware of the Malawian Development Assessment Tool. It's an excellent tool that's been developed over a long period of time that you can use for children from 0 to 6 years. And then in terms of early intervention, there's a lot now available. Therapists don't have to start from scratch about where do I start for early intervention. So just some of the ideas, there's the UNICEF Early Identification, Inclusion and Intervention Program, the ER START, which is early intervention based in the UK. They exist. Therapists don't have to go looking for something. They're there. Okay, so if I say that second point was screening programs and early identification services available at clinic level, I would say there's screening tools there, staff can be trained, can it be integrated into a well baby clinic, can you have appropriate early intervention programs? And I would think that this is almost achievable. Whether it can be achievable at clinic level will also depend on availability of staff. But the fact is there are screening tools available that are not expensive, and there's heaps of information about really good early intervention programs. Okay. Third point, every individual, so not just children, teenagers, adults, is routinely reviewed by a medical and rehabilitation team. So here's where I'm talking to the doctors. When you assess a child with CP, how many children with CP are actually just routinely, every 6 months, have a checkup? Or do you see them when their fits are out of control? Or they've got an acute medical problem? So what would a medical review look like? And here are just some suggestions. The first thing is hip surveillance. I'm on a bit of a mission about hip surveillance. Once a hip is dislocated, it's out. You can't fix it. Children who are level 5, there's nearly a 90% chance the hips are going to be dislocated. Level 4 children, about an 80% chance. Hip surveillance is an evidence-based tool that can prevent hip dislocations. And all that it requires is routine x-rays, where you then check the migration percentage. And when the migration percentage is more than 30%, that child then is sent for soft tissue surgery to prevent and to keep the hip in. Salvage surgery for hips just doesn't work. And in countries like Australia, Sweden, the percentage of hip dislocation is minimal. So this for me, it's like a no-brainer. there's a Australian hip surveillance guidelines. There's absolutely heaps available on the internet about how to do it. So I think and knowing that our children are level 4 and 5, if we allow hips to be dislocated, we are condemning the children to an adolescence filled with pain. A painful hip is really hard to treat. And then if you do your salvage surgery, you end up with one leg significantly shorter than the other, a skewed pelvis, a scoliosis, impossible to seat the child, and very difficult to control the pain. So hip surveillance, epilepsy, growth monitoring, assessing the accompanying impairments and comorbidities, visual screening, hearing screening, levels of pain, constipation, urinary incontinence, respiratory system. There are so many young children who snore when they breathe, have great difficulty with airways obstruction. And as the kids get older and they're level 4 and 5, and you get the rotation of the rib cage and the scoliosis of the spine, so your respiratory function is compromised. Problems with sleep. There are some drugs that you can use for spasticity, dental care, referral to specialist services, psychosocial support, and having a look at the family, family physicians. And then I think depression is hugely underestimated, both in families as well as in teenagers. So a huge role for medical review. So every individual with CP is routinely reviewed by medical and rehabilitation time. I certainly think is possible. Time is obviously a problem, but actually doing it, I don't think is impossible at all. Number 4, regular growth monitoring with provision of nutritional support. So that would include monitoring the growth, baseline nutritional assessment, including anthropometry and biochemistry, managing malnutrition, dietary and nutritional advice, nutritional supplementation, and to supply a blender. I think there's a big tick there. Every hospital, I think almost every hospital has got a dietitian. And when I did a survey of hospitals in KZN, I certainly found that provision of supplements and assessing children, you could tick all boxes there. And in KZN, some of the dietitians could actually supply blenders. So what's the point of a blender? Those children that have severe problems with chewing, remember most of the children are level 4 and 5, so they're going to have problems with chewing. And so, and just getting food into the child. So the provision of a blender, just to make whatever the family eats, you just blend it up so the child then has a thick liquid that they can drink. However, for a blender, you obviously need electricity, which isn't always possible. But I certainly think that there's no reason why we can't be monitoring growth and nutritional status of all the children. Number 5, clear referral pathways to community support systems and specialized services. Okay. So I'll give you the story of this little one here. Tragic. So when we saw her, it was too sad to show you what she used to look like and what she's become now. Her mother left her. She was looked after by her grandmother, and her grandmother is blind. And so she had difficulty with feeding her because she didn't always know where the mouth was. Plus the child had difficulty with, obviously with chewing. So what do I mean when I say clear referral pathway? Which means that this child would have been identified at community level and referred upwards as quickly as possible to have her feeding problems investigated. She probably needed a peg. Would that be possible? And when she had the peg, when she went back to the hospital and she went back to the community, were the support services there to assist her with managing a peg at home? So what is needed? First, you've got to have community support systems available. Is there a protocol? Is everyone familiar with the protocol? Do they adhere to that? Is there transport and is there communication? Okay, so not impossible, difficult, not impossible. Okay, rehabilitation therapy intervention follows current best practice. This is one of my real hobby horses. What is current best practice? Current best is family-centered, it's functional, goal-directed. The focus is on participation. The child and family have to be actively involved, and there must be opportunities to practice in the natural environment. I need to tell you something. Therapy for children with CP is not, it's something we have to try and get out of everyone's minds. It's not about doing exercises. It's not about this. Okay, we're going to do exercises. As you do, if you want to get stronger, you want to get fitter. Children with CP are not going to get stronger, and they're not going to get fitter. Therapy for children with CP is about it becoming and loads of therapy are not going to make the child better. The child has a life to live. Where should therapy have the time? And what is the therapist's role become? Becomes mainly one of that of a coach. How can you do these ideas? Well, firstly, what are the goals? Why are we treating you? What's the goal? And how do we make it possible for you to practice at home? That's practice and training. So, as a therapist, this is one of my little bugbears. When I say goal-directed, therapists, when I ask them what their goals are, they say they're going to improve trunk control, improve head control, improve balance, normalize tone. You will find that in almost every child's file. And the treatment will be passives. Stretching, and they get placed in developmental positions. Okay. The child with C, a level 4 child, is never going to develop trunk control. He's never going to develop head control. He's always going to have CP. You're never going to normalize the tone. It's atypical to start with. We can't fix it. We cannot fix CP. Okay. So what would be more helpful? Ashwin can sit in his buggy for 45 minutes without pushing into extension while his mother sweeps the yard. Okay. He's sitting there, he's not crying, he's not on his mother's back. She can put him in there, he's happy there, and she can get with the therapist. And that determines what it is you're going to do in therapy and how you're going to practice that at home. And then suddenly you see, oh, when we achieve the goals, we can now notice progress. As opposed to just continue doing your stuff at home. I'm not surprised mothers stop coming at the age of 7. Note the children, a level 5 child is never going to sit on his own. The moment you label him as level 4 or level 5, you know he's not going to level 5, and these functional levels have shown to be stable over time. It's not like you're going to go from level 5 to level 4 to level 3, and then one day you're going to sit. I'm sorry. Level 5 means level 5. So let's have a look at what's possible for that child to do. He's not going to learn to sit, but he can communicate. He can engage. He can laugh. What makes him happy? What's going to improve his quality of life? Not being stretched every day. We certainly have to do things that his body's not going to get stiffer, so that when he's a teenager, he can still sit in his chair and we can still pick him up and change and dress him easily. Okay. So therapy intervention, is it based on current practice? Hey, man, I'm a therapist. Of course, I'm going to say it's possible. There's no excuse for that. There's no excuse for therapists to be practicing outdated. useless, ineffective therapy, particularly if that you've only got 35 hours with the child. How much is enough? What is a sufficient dosage? I can tell you, I have scoured and scoured, and there is no answer, because it depends on the child. It depends on his age, it depends on his abilities, it depends on his associated impairments, it depends on his environment. So it's not like a tablet, take this 3 times a day. However, lawyers are not interested in hearing that, actually. So they've got to come up with an amount. Okay, so I've come up, Jillian suggestions, to say this is what I think is reasonable. And of course, it's going to vary according to the age of the child, according to lots of factors. But this is like a starting point that I would say these are recommended guidelines. And what I want to suggest is that we try this. We try this and you tell me. And I've been doing some exercises recently, also to say that if the child was in the public health system, how would you actually do this? How could it actually work? So we're now in the process of saying, is this possible? And when I say therapy, it's not so many hours of physio, so many hours of OT, it's therapy. Sometimes the child need a lot of help with eating and drinking. Other times they may need a massage, and those will also change over time. So this is all therapy. It includes fitting of devices, home visits, report writing, caregiving. It's putting it all together. It's like this package. And some years children may need less, and some years they may need more. And as you will see, it doesn't stop at the age of 7. There's a word there that says for life. For life. Okay. How might you provide that in a public service setting? So I've done lots of different calculations here about how it could be possible, and worked out that this following is possible, in that if a child attends a group setting, as long as the group is well run and is useful, you could get 15 hours. If every child could get 10 one-on-one individual sessions per year at their base hospital, if every child could get a home visit, and if every child could get an intensive therapy block. So this, Madweleni, is really the gold standard here. Ask Thandi how it was done, but it is possible. I think it's not impossible to get to those dosages. And in the provinces where there's a centre of excellence, as I see, that is what the centre of excellence would offer, is that you can increase the dosage and the frequency of therapy. So is this possible? What do you think? I think so. Because that's what happens if we don't. Okay. This is one of the children I worked with early on when I was at Malamulele onward. He was standing in the standing frame 10 years later. So you see kids when they come in like that, they're not born like that. No child is born like that. But that's if we don't take what we do with the kids seriously. To tell you this story of this man and his father in Lesotho. And he's at a school, and he did really well. He has spastic diplegia, and he has a beautiful voice. He leads the school choir. And we struggled and struggled, but eventually we got the right equipment for him. And I learned a lot along the way about what kind of equipment, what sort of device, what sort of wheelchair works. And he did really well at school. And I would go along, and we'd run some training. There was no therapist at the school, but the teachers, how's this? The teachers were trained, and we divided the kids into different groups. And each group, from 8 to 9 every day, was therapy. All the kids, run by the teachers. And what he has, his task shoes. That was his job every afternoon. And he developed terrible contractures of his system, but he could still get in and out of his wheelchair. And then at the age of 18, he now graduates from school and at home. And what a challenge that was to say, now he's at home, who's going to fix his wheelchair? How are we going to maintain his wheelchair? And all the problem solving we did, that's another story on its own about how we got that right. And this is Lesotho, where everything's on a mountain. And in fact, where he could go in his wheelchair was only around his yard. His church that he used to go to was at the top, and he actually had to crawl. And I really couldn't figure out another way of getting him to the top of the mountain other than by crawling. The thing about this young man, he had done so well at school, and then he goes home. And that's another thing we don't think about. So happy to get the kids at school, but what happens when they graduate from school and they're at home? What services do they have then? So here he had a very full life at school, a very productive life at school. And now he sits at home, totally isolated, social isolation. Okay. So the things, well, what then does he need? Because we're thinking about something that's holistic. And what does he want? And the whole process was interesting, sitting with him and his father, saying, well, what are you going to do now? Now, at school, one of the things I learned at school was to look after animals. So if he had some chickens, he could look after the chickens. Okay, so how are we going to get that? So then you partnership. If you will build the chicken run, we will find the chickens. Okay, so we get a phone call, they've built the chicken run. They've sent us a photograph, so we provide the chickens. And then about 6 months later, I was sent a picture of a tray of eggs. Okay, so that then gives him me, he can look after chickens. He can get out of his chair, he can look after the chickens, and he can collect the eggs. All right, so I think sufficient dosage of therapy. Am I going the wrong way? Well, I think it's nearly possible. Okay, moving on, we're going to, so assistive devices, there's a range of them, and I'm very much promoting the idea of a low-cost teaching, that for me, there should be no reason why you want the children, particularly your level 4 and 5 children, you want them to be, they're not going to learn to sit on their own. So one of the best things you can do is provide them something to sit in as early as possible. Yes, when it's early on, you can use boxes and basins, the washing up basin works brilliantly. But as they get older, you need something, and here's a low-cost mechanism made by parents, who's developed a bit of a business out of it, low-cost chairs, standing frames, mean a wheelchair. Then I want to tell you the story of this young lady from Limpopo. Very bright, non-verbal, went to school for one day. They didn't know what to do with her, so they sent her home. So she's in a wheelchair, but look at that hand function. She can't get, she's stuck there. She's either stuck on the floor, leaning on her legs, which is why she's developed contractures and deformities, because that's the only position that she was stable in. So over time, contractures of the knees and feet. What was the best thing that we could do for her? A motorized chair. That's what you want, participation. Okay, it's possible. Do we think that's possible? I would say the budget is often the biggest problem, and it's not just issuing the device, it's maintaining it and making sure that as the child grows and their needs change. Okay. Can the care and rehabilitation services, can they be delivered as close to the home as possible? We heard yesterday as well the out-of-pocket expenses for people having to, and particularly if you can put the child on your back. But what happens as the child gets older and bigger? So is it possible for therapists to be, and I think suddenly when you do things differently, you see this is much more effective, where you see the child in his own natural environment. So is this possible? What do you think? Not impossible. Okay. level. So supporters are persons with a similar life experience who have received specific training. So that training is important. If you're a mother of a child who's a level 5 CP, your experience is different to that of a mother of a child who's maybe got a child with a hemiplegia who can walk but has a cognitive problem. Okay, so if you're going to train parents to be peer supporters, they need to know much more than they would the information you just give them as a parent. They need to be able to counsel and advise other parents about all aspects of the condition. So whether it's a spinal cord injury peer supporter or autism or CP, those mothers need extensive training so that they know a lot more than just how the condition affects their child. They're credible role models, and that's been the most important. They speak from experience. So when, as therapists, we struggle and struggle and struggle to try and help parents, to teach parents about the importance of good positioning. What I've struggled for 3 years to do, a peer supporter can do in one session. She's believable. She's done it. Okay, so peer supporters can support and extend the reach of the therapist. They often act as an early warning system at district level. Hey, this child's getting into problems. And there's evidence to show the difference that they can make, particularly in lifelong disabilities. What is needed, though? Oh, firstly, to say the number of examples. So Malamulele Onward pioneered the carer-to-carer program for parents with children with CP, but there's also WHO has got the caregiver skills training, which is for children with autism. And then there's this LEAP CP, which is also parent-driven, which is in the rural communities of Australia. The biggest difficulty with that, I believe that it really will solve so many problems. Training's not a problem. Supervision and mentoring, yes, you've got to get the therapist on board because often the peer supporters end up knowing more than a newly qualified therapist, so it can be quite threatening. But once you see that you're a team together, most of the peer supporters are supported by NPOs, so that's sustainable. Question I say to you, if we did all of this, would we have a country where every individual feels loved and valued, is healthy, feels included? Yes or no? It's a very small yes. So how do we make it happen? What can you do? Okay, and there's some big problems that we can't solve, but they're problems that we in our own sphere, whether you're a doctor, whether you're a therapist, whether you're a nurse, whether you're a policymaker. And here's just a few pleas, I guess. So to doctors, so be informed about CP. Every doctor should know about hip surveillance. Every doctor should know about GM-FCS levels. Every doctor should know the basics of what's important, that, children with CP need to be healthy. Listen to your MDT colleagues, the therapists as well. And that I find is so much more of a problem in the private sector than in the public sector. And how do you implement guidelines? Therapists adopt a new mindset. Get rid of old, outdated ideas that don't work. Be willing to do things differently and embrace self-directed learning. And to nurses, I say compassion. If you've got a child with CP in the ward, listen and that's something that breaks my heart. The number of children that I have seen die in hospital because their parents weren't allowed to be with them and the nurses didn't know how to feed them. And the kids then got into trouble, felt no. Policy says mothers can't be, etc. And then the child dies a miserable death on their own. Listen to me and take pain seriously. So, yes, we can. Thank you.
Thanks, Julian. That was great. And if you want to ask me how to set up a service, CP service. You'll also need lots of time, because I can go on and on. But I think definitely the biggest thing is that I've at least learned, and hope most people will learn, is CP is a way of life. And if you remember that concept, and also you can get me talking about ICF forever, but meaningful therapy and always looking at inclusion, participation, and the caregiver's needs. And that's been the biggest thing is that has changed our service, is having the peer support, caregiver training, and having a look at how can we make that part of their lives and include them and have meaningful therapy. And I think the biggest thing for me was that I think it was the first time Gillian came to visit Madeleine, that it was possible to treat a complicated case. And that complicated case is now a teenager who is still very happy, and she started living as a teenager. And so, yeah, thanks, Gillian. And I really do think it's possible. We won't get everything there. It'll take time. But when Gillian says, take it or leave it, what Gillian says, it's with a lot of experience, lots of hospitals she's visited. But yeah, so we take what Gillian says, adapt it, and it works. But last of all, CP is the way of life.